All right, let's close out this section talking about bacterial infections and so forth of the skin and integumentary system. Now, folliculitis is the infection of the hair follicles, typically caused by staph. Staphylococcus aureus is organism that's typically found on our skin. Treatment is relatively simple and straightforward: soap and water, as well as topical application of antibiotics. And then we also have furnicles, which are boils, the inflammation of the hair follicle, and it develops from preceding folliculitis and spread through the follicular wall into the surrounding dermis. Once again, Staph aureus is also the most common causative agent. And so here is the traditional boil or furnicle. A carbuncle is a collection of infected hair follicles. Erythematosus is reddened, painful, swollen mass that drains through many openings, leads as kind of a precursor to that of abscesses. In clinical manifestations, systemic symptoms that occur during early stages, chills, fever, malaise. Treatment, warm compression to provide comfort and provide the localization and spontaneous drainage. Sometimes I&D is required to treat the abscess formation, and the systemic antibiotic administration. Cellulitis involves the infection of the dermal and subcutaneous or hypodermal areas. The cause is typically by staph or a group B streptococcus. Treatment, systemic antibiotics, burl soaks to relieve the pain, and sometimes corticosteroids as adjuvant therapy, but oftentimes we're looking at using systemic antibiotics. We try to get those managed as an outpatient, but there are times that we do have to admit for inpatient management. Now, from an inpatient perspective, the most concerning infection and life-threatening infection, or one of the two life-threatening dermatologic infections, is that of necrotizing fasciitis. It's a rare and rapidly spreading inflammation starting in the fascia, involves the muscles and subcutaneous fat with subsequent necrosis of the overlying skin. Treatment is pressure support with antibiotics and fluids, IV fluids, antibiotics, and surgical debridement. This is a life-threatening emergency. And then going the other end of the spectrum, where we have bacterial infections that are not life-threatening but are still annoying. The erysipelas, which is acute superficial infection of the upper dermis, and this is superficial. One way to look at it is a superficial form of cellulitis, and treatment is that of cold compresses and systemic antibiotics. And impetigo is commonly seen in children. It's a superficial lesion of the skin, typically has that honeycomb crusting appearance, and is caused by coagulase positive staphylococcus or alpha hemolytic streptococci. Viral infections, we talk about HSV 1 and 2, herpes simplex. Kind of the way I remember this is HSV 1 is above the belt, HSV is below the belt. As far as HSV 2, HSV 1, you get contact with infected saliva, you get those cold sores and fever blisters, most common manifestation, and treatment is topical antiviral agents. HSV 2 is more serious. It involves the genitalia, skin-to-skin mucous membrane contact during viral shedding, vertical transmission from mother to neonate, and it is associated with significant neonatal morbidity and mortality. And treatment is that of topical or oral antiviral agents as well. The picture here shows HSV 1. Now, within the herpes simplex, or the herpes family, I should say, we also have chickenpox, which is varicella, and then we have herpes zoster, which is shingles, that we'll talk about now, both of which are caused by the varicella zoster virus. And the initial infection with varicella followed by years later by the herpes zoster. So we don't see this as much anymore as far as chickenpox because of the immunizations. However, we are still seeing quite a bit of shingles, and there is a new shingle vaccine that is out, Shingrix, which is a two-step injection series. But best thing to think about this is that you have the varicella that occurs first, and then you have a period of dormancy, and then you have the herpes zoster or the shingles. Pain and paresthesia localized to a dermatome, so this is dermatomal specific, and then followed by a vascular eruptions along the face, the cervical or thoracic lumbar region. Treatment, there is no cure, although compression, calamine lotion, and baking soda are used. If we catch it early, antiviral drugs can kind of shorten the period. We need to get it going within 72 hours for best efficacy. Pain management is key, particularly with herpes zoster. Topical lidocaine patch, gabapentin, Lyrica, sometimes used. Very recalcitrant cases. We'll look at using controlled release narcotics, long-acting narcotics. Although, even in my experience with doing chronic pain management, we really try to optimize using neuroleptic medication, anticonvulsant medications, because that controlled release narcotic is not going to do anything other than block the pain signal. And it's hard to get adequate pain control with narcotics or opiates in this type of pain. Tricyclic antidepressants really work, particularly if you use them at night. And then sometimes the topical capsaicin will also help. This picture is that of shingles, and you can see it's following that dermatomal pattern. You see that clusteration of the vesicle formation. Warts, they're benign lesions caused by the human papillomavirus or HPV, transmitted by touch. Also, walking barefoot on a wet surface will sometimes do it. Clinical manifestations, you'll get that rough grayish surface. Clinical diagnosis, treatment, freezing with liquid nitrogen, electrocautery, and vaporization with lasers for recalcitrant warts. Freezing with liquid nitrogen, sometimes will help. There's always the concern it could grow back. The other concern is the pain and the discomfort of having that treated. Application of keratolytics or application of irritants and corrosives such as salicylic acid, formaldehyde, interferons, or podophyllum. Now, as a side note, in clinical anecdotal note, is treatment of is the use of imiquimod, which is the generic name for Aldara, Aldara, which is medication. It's a topical cream. It comes anywhere from 2.5 to 5%. Used for a variety of conditions, including basal cell carcinoma, actinic keratosis, but also external genital warts. But what we've found in the clinical setting is that you can use it for common warts that occur on your hands and feet. And what you do is you apply a small amount of that to the warts 3 times a week at bedtime. You leave it on for 8 hours and then you wash it off. And you can use it up to 16 weeks. And insurance companies will typically cover that. And we've had really good success with that. Condylomata acumenta, or venereal warts, highly contagious, sexually transmitted. Clinically, you'll have a cauliflower-like lesion occurring in moist areas along the glands of the penis, the uvula, the vulva, and the anus. And then we have the oncogenic HPV, which is the primary cause of cervical cancer. Fungal infections, fungi causing superficial skin lesions or dermatophytes. Fungal disorders are called mycoses, MYCOSES. And mycoses are termed tinea when caused by dermatophytes. So tinea capitis, involving the scalp, tinea pedis, athlete's foot, uh, tinea corporis, which is that ringworm, tinea crucis, which is the groin or jock itch, or we also have tinea unguium, which is also the onychomacosis, which of the nail, the discoloration or the fungal infection of the nail. Diagnosis is by culture and microscopic examination of the skin scrapings prepared with potassium hydroxide wet solution as a wet mount, and then also through the use of a Woods lamp. And treatment is the topical and systemic antifungal agents. Um, Candidal infections is caused by the organism Candida albicans, normally found on the skin and the GI tract as well as the vagina. Albicans can change from a commensal organism to that of a pathogen, and that depends on the host, so the human. Local environment of moisture and warmth, the systemic administration of antibiotics, pregnancy, diabetes, Cushing's disease, debilitated states, young age, old age, immunosuppression, and neoplastic diseases. And this is that yeast infection that you'll typically see clinically is a thin wall pustule that produces a whitish yellow curd-like substance. And treatment is topical antifungal medication. Cutaneous vasculitis, inflammation of the blood vessels of the skin, and results from immune complexes in the small blood vessels that activate the complement. Developed from drugs, bacterial infections, viral infections, or allergens. Systemic forms of lesions, you get the palpable or purpura, progressing to hemorrhagic bullae with necrosis and ulceration. Treatment, antigen removal, corticosteroid, and immunosuppressant administration. And this is the picture of the cutaneous vasculitis that we see. Urticaria, hives. Hives are due to a type 1 hypersensitivity reaction to allergen. And you have a histamine release causing the endothelial cells of the skin to contract, and then you get leakage of the fluid from the vessels. And that's where you get that hive appearance. Clinical manifestations, you'll get this pruritic, circumscribed area of raised erythema with central pallor, wheals, and welts. Treatment, antihistamine. Once again, this is due to histamine release. So if you block that antihistamine, the leukotriene receptor agonist, as well as alpha adrenergic agonist and steroids. This is a really good picture of hives or urticaria. Localized scleroderma. This is where you get sclerosis of the skin that can progress to muscles, bones, and internal organs. Your T helper cells, your TH cells, TH1 and TH17, as well as their cytokines. You have a fibroblast proliferation and fibrosis, and it's associated with several autoantibodies. Clinical exam of the skin is hard. You have that scleroderma, so it's that tightening, hypopigmented, taut, shiny, and tightly connected to underlying tissue. It's hard for them to move. Treatment is that of suitable clothing in a warm environment, avoidance of trauma and smoking, immunosuppression, and UV treatment. This picture here shows the scleroderma, so you can almost visualize the pain and the agony this person is going through. They have a hard time fully extending their hand. Their skin is really just becoming taut and shiny. Now let's talk about ticks. Tick bites, they embed their heads into the skin to obtain the blood, and they engorge on that blood, enlarge to many times their normal size. The problem is they release toxins or transmit microorganisms during feeding. So treatment is prevention, tick repellent. But if we actually have clinical suspicion of disease, then oftentimes like Lyme disease, Rocky Mountain spotted fever, then we start looking at different treatment algorithms. Lyme disease is multi-system infection from the spirochete Borrelia burgdorferi, most common in children. And stages goes from a localized infection to disseminated infection, and then sometimes there's late persistent infection. So the localized infection duration is 3 to 32 days with a bullseye's rash with or without fever, fatigue, malaise, myalgias, and arthralgias. So they are tired, they hurt, they have this rash, they may or may not have a fever. And then we get disseminated infection. After that initial infection with secondary bullseye rash, then they usually present with arthralgias, meningitis, neuritis, and there has been cases of carditis being exhibited. And so you don't want to miss this diagnosis. Late persistent infection, we typically don't see that as much in the United States as we do overseas in Europe, and it can continue for years with arthritis. Worst case scenario, the person is encephalopathic, polyneuropathic, or in worst cases, they lead to heart failure. Treatment, doxycycline or amoxicillin predominantly in children, whereas the doxycycline is not used in children younger than 8 or in women who are pregnant or breastfeeding. And the reason is that is because it can cause permanent discoloration of the teeth. According to several drug databases, tetracycline can be used in life-threatening cases or when the benefits are expected to outweigh the risk in conditions such as anthrax, Rocky Mountain spotted fever, when there are no alternative treatment options available. But ideally, we want to avoid doxycycline in the pregnant population as well as the young. Benign tumors, we get the seborrheic keratosis. You'll get proliferation of cutaneous basal cells that produce smooth or warty elevated lesions. And treatment is with cryotherapy with liquid nitrogen or electrocautery. There's also the keratoconthoma, which are tumors of the squamous cell differentiation arising from the hair follicles. And the treatment is the curettage or excision, sometimes also introducing intralesional 5-FU, bleomycin, interferon, or methotrexate. So on the left is the seborrheic keratosis, whereas on the right is the keratoconthoma. Actinic keratosis is a premalignant lesion composed of aberrant proliferations of epidermal keratinocytes caused by prolonged exposure to the UV radiation, so prolonged sun exposure. Treatment, ablative and topical therapies, 5-FU, as well as imiquimod or the medication that we were just talking about a couple minutes ago that can be used for warts, the Aldura, is used. Protection from the sun. Moles are also known as nevi, and these are pigmented or non-pigmented lesions that form from melanocytes, and they can undergo transition to malignant melanomas. So treatment, depending on the clinical presentation, is surgical excision, and that can actually be oftentimes be done in the office, depending on the size. Sometimes we will also refer out to dermatology if it is significant or more involved treatment is warranted. So here on the left, you have the actinic keratosis versus the right side, you have the moles or the nevi. Now let's talk about skin cancer. So there's really kind of two flavors. There's squamous cell carcinoma and then there's basal cell carcinoma. And, and these are the most prevalent forms. There's also malignant melanoma, which is the most serious and most common cause of death from skin cancer. So if you were looking at a test question and it was asking you, which of the following is the most deadly, basal cell, squamous cell, or malignant melanoma, I would answer malignant melanoma. Cause, chronic UV radiation. So sun exposure, tanning bed exposure, particularly during childhood years, adolescence. Um, and if you protect from the UV radiation, particularly during those early periods of time, this has been known to statistically reduce the risk of skin cancer in later years. Basal cell carcinoma, surface epithelial tumor, pearly or ivory in appearance, is slightly elevated, has depressed centers and rolled borders as it grows. I like to, whenever looking at a skin lesion, looking at the concept of A, B, C, D. And A stands for asymmetry. One half is unlike the other half. B is border. Border irregularity is scalloped or poorly circumscribed border. C is color varied. It varies from one color to another. Shades of tan or brown, black, sometimes red, white, and blue. And D is diameter, larger than 6 millimeters as a rule. And 6 millimeters is about the size of a pencil eraser. Basal cell carcinoma mutation in the TP53 and PTCH1 genes, and treatment is typically surgical excision, radiotherapy, curettage, cryotherapy, photodynamic therapy, and topical applications of Aldura or 5-FU. Squamous cell carcinoma is a tumor of the epidermis, and there's types. There's in situ, which is Bowen disease and invasive, and it's a mutation of the TP53 and other oncogenic signals. And treatment, surgical excision and radiotherapy with consideration for adjuvant chemotherapy. On the left is a basal cell, whereas on the right is a squamous cell carcinoma. Malignant cutaneous melanomas is a tumor of the skin originating from the melanocytes. Once again, we see that A, B, C, D, and they're now adding E rule is used as a guide. So A is asymmetry, B is border irregularity, C is color variation, D is diameter larger than 6 millimeters, and E is elevation that includes a raised appearance or rapid enlargement. Treatment is surgery and immunotherapy. Now, Kaposi sarcoma is a vascular malignancy often associated with HIV and AIDS infection. Drug-induced immunosuppression after kidney transplant, for example, is one way Kaposi sarcoma develops. Is known to be endemic form in the equator area along Africa. Classic form was exhibited on the lower legs of older men. And like I said before, the epidemic and non-epidemic forms are related to acquired immunodeficiency syndrome or AIDS. And then we have the Kaposi-associated herpes virus, or HHV8, which is found in all forms. Kaposi sarcoma clinical manifestations is purplish-brown macules developing into plaques and nodules. Treatment, unfortunately, is incurable. Local lesions, surgical excision, multiple disseminated combination of immunomodulating, cytotoxic, and antiviral medications. And then HAART, highly reactive antiretroviral therapy for treating underlying HIV/AIDS, decreases the incident rate. This is 3 different pictures of Kaposi sarcoma. And then we get primarily cutaneous lymphoma. Either T cell and B cell lymphomas are present in the skin. Treatment is based on staging, range from topical to systemic therapies, anti-inflammatory, immunomodulating, and biological agents. And histone deactylase inhibitors, rexinoids, and chemotherapeutics are often utilized. Radiotherapy is the most common successful therapy known. And let's finish up the last set of the slides talking about cold and heat injuries. Cold injury, frost nip is that mild and completely reversible injury characterized by skin pallor and numbness. Chilblain is more serious with a violaceous skin color and plaques or nodules, pain and itching, and there's without ice crystal formation. Problem with this is it leads to chronic vasculitis develops. Now frostbite, tissue freezes and then forms ice crystals at temperatures below 28 degrees Fahrenheit or negative 2 degrees Celsius and progressing from distal to proximal areas. The thing about frostbite is that it's potentially reversible. And then the last one is flash freeze, which is rapid cooling with intracellular ice crystals associated with contact from cold metal or volatile liquids. Think of liquid nitrogen and the dry ice. So cold injuries is a skin injury from exposure to extreme cold temperatures. It affects the fingers, toes, ears, nose, and cheeks. Burning reaction is caused by alternating cycles of vasoconstriction and vasodilation. And inflammation and reperfusion are part of the pathophysiology. Clinically, they'll have white or yellowish skin, waxy, firm to touch. In treatment, you cover the affected areas with other body surfaces and warm clothing, so keep it protected. Do not rub or massage this area. Best treatment is immersion in a warm water bath at 40 to 42 degrees centigrade or Celsius, which is equivalent to 104 to 107.6 degrees Fahrenheit, until that frozen tissue is thawed. The use of ibuprofen is warranted because it inhibits prostaglandins. And then some are recommending the use of aloe vera, applying the topical inhibitor of thromboxetine. Severe cases, thrombolytic therapy reduces the incidence of amputation when administered within 24 hours. Pain during thawing is severe and should be treated with potent analgesic medication. So this is the time that we break out the IV pain meds. Gentle cleansing and no pressure on the skin should be maintained during healing. So you want to keep that area elevated. You also want to make sure there's no pressure points on that. And unfortunately, amputation of the necrotic tissue should be delayed, or does occur, but amputation of the necrotic tissue should be delayed until a clear line of demarcation is established. And disorders of the hair, as we close out the last three slides, male pattern alopecia or hair loss, genetically predisposed response to androgens, androgen sensitive and androgen insensitive follicles, treatment, minoxidil, finasteride, low-level light therapy, wigs, or hair transplantation. There's also female pattern alopecia, which is elevated levels of serum adrenal androgen, as well as the dihydroepiandrosterone sulfate. And treatment is anti-androgens, finasteride, minoxidil, and spironolactone. Alopecia rosacea is an autoimmune T-cell mediated inflammatory disease against the hair follicles that results in patchy baldness. Treatment is watchful waiting, administration of corticosteroids, minoxidil, and topical immunotherapy. Hitterism is the overgrowth. When I think of this term, I think of the excessive predominance of facial hair on females. So you have the androgen sensitive areas, abnormal hair on the distribution on the face, the body, and pubic area, and a male pattern that occurs in women. And how we treat this, we do endocrine treatment to suppress androgens. And then the last slide is the disorders of the nail. There is pernicia, which is a bacterial, acute, or chronic infection of the cuticle. It's painful. The abscesses may develop. Treatment: hands, you keep them dry. Significant abscesses may need a localized incision and drainage, IND. And then severe bacterial cases, systemic antibiotics. Then onychomycosis is a fungal or a dermaphyte infection of the nail plate. It causes the nail to turn yellow or white. And the treatment for that is typically localized debridement as well as systemic antifungal therapy. Word of caution here is that the systemic antifungal therapy is going to take several months to take effect. So this is not a quick treatment course. And folks, that concludes the last slide of the last slide deck. If you have any questions, feel free to reach out to me. Keep up the good work. Thanks for hanging with me this semester. It has been my privilege and honor to be your guide. If you need anything, feel free to reach out to me. If you have not taken N618, I highly recommend you take that course next, as this is a continuation of pathophysiology, and that course will focus more on disease states and body system and organs. So cardiovascular, renal, pulmonary, um, um, and so forth. So until then, take care of yourselves, each other, and we will talk soon.